presentation on key EPI performance indicators. Before you come in, I've been advised that our presenter has 2 presentations, so we're going to match them in the interest of time. So we're going to do presentations.
Okay, thank you, Session Chair. My name is Allow me to present the performance under the our we are giving based on the different financial year. If you maintain a business, color green, like it is defined for the antigens that are highest 20, that is for hepatitis B, 23% and 45% for the last financial year. So the trend is moving. Meaning that by the time we finish this year, we should be somewhere else. The same applies to vaccine. The other one is with BCG counter check. It's looking at this. So each and every antigen that has green, at least it has surpassed the national target. Yes, coverage above 99, I mean 90 for DPT1 and 90 for DPT. No, 90 for DPT1, then 0 to 10 for drop. Category 2. So those in red, if I may see, this is Kamsandara. This is Kamsandara. They are a bit faint, but this is Kamsandara. This is Rubianabara. Which sub-county is after Rubianabara? This one. This is Kamsandara. Then we have here. We have Mocha. Which other sub-counties here? Okay. We shall see, but those are the sub-counties which are in red. We have this is Tono. We have Charumba. Which other one? We have Charumba, Ihaniro, and Chitoro. So those are the sub-counties which are not performing well. Next. So this is our performance for the last financial year as a district in general. 2021-2022, we are in category 1 as a district. 2022-2023, we are again going to category because of a number of factors. 2023-2024, we are in category 2. Then 2024-2025, we went to category 1 back because you knew we had a lot of interventions here. We had big catch-up, we had a lot of activities that supported immunization, and where we expect good performance. But however, when you look at this table, we still have a challenge. Those children who are broke, For DPT1, most of them don't come back for measles. So we still have, that's why it is colored red everywhere for all the financial years. So as facilities, we need to go back and find out what is the real problem. Next. And this is now our facility-based performance in terms of rate categorization. The first one had rate. Rate is reached every district. When it comes to rate, this is reach every child. And children are reached at a facility level. Are we together? So this is how we performed. And we have around 6 facilities in category 1 who may need at least to be recognized for their efforts. We have Bukangara Health Center in category 1. Then these ones in yellow are in category 2. Those in category 2, we have Bovocho, Bugalitza, Bukoye, we have Buhaura, we have Buhoira, Busunga Health Center 2. We have Buena General Hospital. In category 3, we have to take slide. They are going to continue. Next slide. The same applies here. So the facilities which are performing poorly, if we are giving them priority is here. Priority number 4 from the worst. So meaning that if we are to intensify support, we shall begin with those that are in category 4. Are we together? So if the support supervision that is going, we are prioritizing those facilities that are not performing poorly. Next. So you see the facilities in category 1. We have for Kasese community, we have for Katado, but so basically at almost everything are taking it on. Next. Then again, Lebanon is hospital. Next. Then we have here Nyamgado in category 1. Then as a district, we are in category 1. But we need to improve and reduce all the reds and the yellows that we have seen. Activities done in the last financial year. Police, this is what as EPI department we have managed to do. Support and mentorship in the health facilities. At least we have reached a number of facilities, training judges and EPI focal persons in the 102 health facilities, providing immunization to plan and forecast. Now, introduction of malaria vaccine into routine schedule. Currently, we are giving malaria vaccine, which is given to children of 6 to 11 months. Watch it. For those, then those who can receive those one in that period to give the facility. Engagement of teachers. We are not. So this was a success. We met all the judges and we are working on what was suggested as the causes of alarming. Distribution of vaccines. This one is being done. We are expecting another batch of vaccines to be given to the facilities. We helped successfully big catch-up campaign that supported us. Last year in November. Then we also had integrated child daily days in April, and we expecting another one in October very soon. Then we also conducted the Ebola vaccination to the frontline workers, and we were able to give 473 health workers for dose number 2. Then we also conducted cold maintenance for the fridges. And you see the numbers are there. Though we still have a gap, for those that remained. So, when we are conducting support supervision, things are still being managed wrong. Not being documented. Almost if you visit most of the registers, you find that and colleagues, this is a book that we use for several. You touch the control book. Affirmation monitoring charts. And now this is evident that we are not reviewing our facilities for some counties and town councils. Some others who come to supposed to track them. Why have they not come? And the responsible people for that. And the facilities. Most of our facilities have left vaccination for VHT to practice. Mobilization. There are different things. So we
I wish to organize. Thank you.
My name is Hashim. I work with Kasese district of results. Following percentage of children aged 6 to 9 months are school that is put of the child means the child has severe acute malnutrition. We did not necessarily do well at health facility level in the previous financial year compared to the previous other year. Here it was slightly above the lower one. No. At health facility level has not been that much better. The reasons are many. One is that in the previous financial year, we were supported, the district was supported by UNICEF to conduct a nutrition assessment in 700. These numbers are only for the children that went to the facility. The reports are there. I do well. Several subjects agree, trying to do well assessment for children. Houses agree, also trying to do well. Maliba houses agree, Isule, Mokati, trying to do well. And so is Bukuhia. Those areas that each do well in terms of assessing nutrition status for children. The health facilities around like Katwe, Awatoro, in Kiarumba, those areas in yellow, the facilities there, let's try to improve on coverage as far as assessment is concerned. Then those that hardly do any assessment, those facilities are the ones in red. I can talk without any fear of contradiction that there's not any health facility right now that's not specifically ready to use therapeutic food. And even as of late, the last batch was sent out yesterday. All facilities receive ready to use therapeutic food. So why are we not assessing? And then you're getting the what? The therapy. All of those facilities in red, you are not assessing. You have the therapy, you have, is it that you don't have the tools to use? That you have capacity gaps? Yes, that's what is there. I wish our barrister could show it. However, listen, I know that here in the Nyakatozi sub-county, we have Nyakatozi Health Center 2. That's a big catchment area. So we are not assessing Nyakatozi Health Center 2. When you come to Hibaton Council, we have Hibaton Health Center to read. Why are we not assessing? Even when we benefit every quarter from quarterly monitoring and support supervision services with support from UNICEF. Down here, we have this Attorney sub-county. He told even requested that we should retrieve some of the RITF there. We want to find out what are the issues with Victoria Health Center to read. Now, when you go up there, the churches of the facilities up there, some of you are here, please, we should ponder on why we are not assessing. You have the tools, the data collection tools, the primary and secondary tools. Every other quarter you're getting capacity building in terms of nutrition service delivery. So what's the problem? Why are we not assessing? Let's proceed to the next. This is nutrition service delivery, only 52. That is the vitamin A second dose and the one with second dose. You could also realize that in the previous financial year, the levels were relatively lower compared to the other years. Why? In the same exercise, when we were reaching out to schools, we were not only doing nutrition assessment, but we were only giving vitamin A all children that did not get in the previous childhood days. We are also giving the folic acid to our adolescent girls in primary schools. We are also giving the dewormers. So, I believe that this is the health facility data, but most of the children were met in the communities during the integrated school strong community nutrition outreach exercise. And we gave out the orders to more you the health worker failed to interpret or to report through the mother. It is the same process. The mother have the second dose that you end up reporting it as the first dose. And therefore you are rendering the service to your soul. You are recording where you are supposed to report, and when we report, we report. Yet you measure people. That is why. Also, the other challenge, sometimes you enter this data at the end of the day when you have finished working, and you lost the track of how many you received from where you put there the figure of complicity. And so the figures end up getting low. So I can say that we are performed here at 12% level, but the community, we did our work. So some performance outcomes. We have 4 performance outcomes for some. I said some means severe acute malnutrition. So the first performance outcome is the cure rate. We expect the cure rates to improve compared to the previous one, to the previous years. How do we measure cure rates? A cure rate, who is the cure anyway when it comes to nutrition? A person who has come with maybe severe acute malnutrition, they are nice and has entered the criteria for what for this year. That one is a cure. So in Uganda, a cure rate of some that is above 75% is the best. So if for you your cure rate at your facility is less than 75%, you are underperforming. in terms of nutrition service delivered for treatments. So we picked out facilities that are reporting on those indicators, and you can see Kagando has a good cure rate that is above 75%. Thank you, Kagando, for putting service delivery above safeguard. We also have Kahengero. Kahengero has also 8.9%, so it's a general hospital. The rest are reporting, but you picked a few, you can see that your cure rates are still low. However, you can attribute this to the number of patients you receive. You may be receiving maybe, let me say, 2 clients, and none of them will improve. Your cure rate is going to be extremely very, very low. Compared to the person who has received 50 clients and 45 will improve, so you can see that difference. When it comes to, however, there are other facilities that do not report at all of cure rates, and these are the things that inform planning and programming. So if you are getting therapy, and at the end of the quarter you don't show us that the therapy did this work in terms of either curing of your clients or others, right? What it gives you the ground to request for the next therapy if you don't give us the outcome. So facilities that are not reporting on the cure rates, for example, Chirano, Kirangoge, Resort Mountaineering, and the rest, let's improve on that indicator. We have the death. The death is a person who has been treatment, given the right treatment, has spent the right amount of time, but has failed to respond to the treatment. And they end up dying the program. So the World Health Standard and so on, the Ministry of Health Uganda says the death rate in Uganda for nutrition is supposed to, for a facility, is supposed to be less than 10%. So if you are definite that the facility is above 10%, those are the people you see in red here. The facility is in red. Others don't report because they say they don't have this. But you can look, for example, I called the nutritional person Flavia, so go at your Kobe Health Center for. Why did you get a death rate of where is the Kobe? Why do you get a death rate of 8.7? A government hospital, a death rate of 8.7. So that's all her 6 clients dying program with severe acute malnutrition. And she attributed the factors one to lack of therapy. We actually did have the inpatient therapy for children with severe acute malnutrition. Remember, these children do not give them RIT. To give them formula F75OF, none of the facilities in the district had that in the previous one. We were at the mercy of locally available milk which we will buy, then we work with the mother to see how we can reconstitute it to make the World Health recommended health center. So we